Good evening, everyone. Thank you for joining us. This is Holly with iCare. We are pleased to have Dr. Caldwell joining us this evening, going to be reviewing some cases for retinal imaging that he has in his practice, and hopefully will be enlightening you on our technology and what we have to offer. Take it away, Greg.
Hey, Holly, thanks. And thanks everyone for joining. Thanks, Jobson, for putting us all together. We're going to be doing elevating retinal imaging here tonight. I want to kind of point out to everyone is that I'm not being compensated for this presentation. I happen to do a lot of education, and I have a presentation called Latest Innovations in Eye Care, and I presented this recently. It was a new lecture that I did in September, and one of the iCare team members happened to be there sitting in and really liked it, reported it back to iCare. And so I'm going to kind of just do what I did for education, just to kind of highlight, as a ocular disease consultant in Pennsylvania, and being an educator, how this lecture came about. And I'll just kind of show you by going forward here. So I'm lucky to have two cameras in my practice. I do have the Optos, and you can see it there. That's the picture, what it looks like in my practice. And I do have the Eidon from iCare. And really why I have two cameras is, if you want to say the Optos is good for screening, it's good for the routine stuff. But as an eye disease consultant, and now with optometry doing more and more with glaucoma, diabetic retinopathy, macular degeneration, working with, cataracts, people with asteroid hyalosis, I needed something that I could really hone in. We have this structure function thing, and that's out there. And this is a, picture of structure. We rely on OCT. And then really more importantly out there, we have AI coming. And, if you're going to train AI, you need good pictures in a sense to train AI that's out, that's going to be part of our future, whether you like it or not. So, a disease, I work in as an ocular disease practice. I get a lot of referrals. I get a lot of, macular degeneration, diabetic checks, so on and so forth. So I need photography to see details of the optic nerve and retina, whether it's the posterior pole, periphery, or the nerve fiber layer dropping out. Ultra high resolution to see the fine details of the optic nerve and retina. And what's really, big about this, and, I have a slide that I forgot to put in here, a picture. It's a student standing up at the board. It's a big math problem, and it's got step 1, step 2, step 3. And step 3 says a miracle occurs here. And, the professor said, well, you need to be a little bit more explicit here in step 2. That's kind of how this camera works. And we have some of the iCare people and Eidon, staff on here tonight and sales, and they can discuss the confocality of this. But what that really means to me is I'm able to see through small pupils. And as people get older, you see what happens. Patients' pupils get smaller. There's opacities, there's asteroid hyalosis, and it's hard to get a good image, but I think you're going to be pretty impressed by some of the images that you see tonight. And then TrueColor, it uses white LED. You get fundus appearance, which looks just like you do with your 78 and 90 diopter lens when you do a dilated exam. So the Eidon camera, has unsurpassed ultra wide field image quality, TrueColor confocal technology. There's an ultra high resolution and ultra wide field. I believe it goes up to 200 degrees. We can confirm that, but I know it's, you'll see some of the pictures here that I do tonight, how far we can get out, and it's high resolution. So not only is it ultra wide field, but again, it's that, resolution, which I'll point out, 2.5 millimeter pupil size to get a picture. And, it's not unheard of whenever, the patients age and those pupils shrink. That's out there. I just looked at my schedule today. My average age was, I saw 25 patients, was 81 years old. And my youngest patient, still in a bifocal at 62. So you can imagine the pupils and the reason why I need to have a a camera that can do 2.5 millimeter pupil size. Really easy to use, minimal staff training that's out there. And it's got a complete suite of fundus imaging. We have, fundus autofluorescence, and really with geographic atrophy, that's with the new medications out there, Apellis and Astellas with, Izervay and Synfovry. That's the reason why I went with this, to be able to follow the patients with geographic atrophy. So again, there's the TrueColor confocal technology. It's unique. It's high resolution imaging. Is well known in optometry as a standard, and we have the ability to do it with with this Eidon camera. So let's just jump into some case studies. I think this is really where the camera kind of really shows its superiority that surpasses some of the imaging that's out there. So here, grade this diabetic retinopathy. And again, I have the ability in my practice, and I'm not here claiming superiority. I'm not here to really trash any company. It's just, I have the ability to be able to have both cameras. And we have a pretty good wellness package in our practice. And so a lot of people will get, the wellness package. And with that, we will use the, say, the Optos camera. So here was a patient that came in. Maybe it was the first time. I don't really know the history, but we'll just say it was the first time they're in. They get the wellness package. And I'm like, okay, this looks good. Now, granted, I can take and adjust and move and do different filters, but I really don't want to have to do that. I want to be able to take a picture. If I bring up this picture, and put them side by side, if you would grade this diabetic retinopathy, you might grade it as, mild, trace to mild. But when you start looking, you can now, if I grab my pen here, you can start seeing all these different types. Here's all the exudates we have around here. So we know there's some leakage going on here. And if you just look around, you could see that there's just hemorrhages. And I think we know that when you're grading diabetic retinopathy, basically you're just grading ischemia. How ischemic is that retina? So my picture with the Optos, I might grade that, a little bit less. And why is that important? Because I might follow up a little bit longer than I would, with the picture on the right with the Eidon. So I think, this is just two pictures, same day, side by side. And I think we would all grade that diabetic retinopathy, with the Eidon camera a little bit, a little bit worse, which clinically that becomes, a bigger deal. Here's another one with diabetic retinopathy. Again, we get to see a nice, kind of wide field here, but we lose that resolution whenever we put, the picture side by side. And again, you can see nice wide field, and I'll show you pictures here where you can literally stitch 3 pictures together and get that 200 degrees. But you'll see here now, if I grab my pen and start to draw, look at all these extra hemorrhages that are out here. We got a whole bunch in this area here. Now, again, I can come over to this picture, and now that I see them, we can again just the contrast and use the different filters and maybe get them to jump out. But I just like, if patient has retinopathy, to be able to get a nice, clear understanding of what's happening. And, with this TrueColor technology, which the iCare's staff can definitely get into a little bit more detail. Again, to me, a miracle occurs, but it just gives me a better picture. Now, again, I made the comment on, artificial intelligence, whether you like it or not, it's going to be coming. Which picture do you want to train, your system on, or the AI on? I think obviously it wants to be this picture over here, and going forward and plugging that picture in to monitor that patient. So that's not here yet. So, I can follow this patient. I might follow this patient 2 or 3 months sooner. I might, read them the riot act a little bit better about getting their insulin under control, or, their hyperinsulinemia under control. I might do some more function, discussion with them. It's just not about, to me, I did some functional medicine training now. So I do a little bit more than disease management. I teach them that, the hyperinsulinemia is what causes a lot of the metabolic conditions, not just diabetes, but obesity, hypertension, dyslipidemia. And that, a lot of the type 2 diabetes out there, if we were disciplined, we could really cure it, right? We could set back with good exercise habits. We could do good sleep habits and good nutrition. And we could probably solve, let's say, 90% of the type 2, not type 1, but type 2 diabetes. And you'll see here with what I've done with a patient and how the diabetic retinopathy improved. Now, here's that, 200 degree. It takes the 3 high quality, high resolution images and puts them side by side. And now what I'm seeing on this picture right here is a blot hemorrhage. Now, we always clump dot and blot hemorrhages together. So I always like to, ask the audience, is there a clinical difference between a dot and blot hemorrhage? There's 3, to me, what I would classify blots right here. And I'll just take away, I'll clear those. And you'll see that, is there a clinical relevance between a dot and blot other than size? Then the answer is yes. When you have blot hemorrhages, there's more ischemia going on in that retina. Why does it go from a dot to a blot? It goes from a dot to a blot because Mueller cells are dying, right? Mueller cells compared to a photoreceptor take a lot less energy, take a lot less oxygen. So if Mueller cells are dying and you see blot hemorrhages, I'm going to follow that patient a little bit closer. Now, I really don't have these pictures down below of the optos blown up, but I can tell you that whenever I was evaluating, these blot hemorrhages and looking at this image, I had to do a lot of adjusting and playing around with the different filters to be able to see this. And again, I think that's just the beautiful part of having, the true technology out there to be able to pick up, because I'm going to follow this patient a little bit closer. This tells me that this eye is a little bit more ischemic. And so that allows me to do a little bit better clinical care in discussing with this patient. All right. So here is access, assess the neuroretinal rim and the nerve fiber layer of this patient. And you can see here, this is a patient of mine. I have the initials up here to remind me this is a glaucoma patient. And now it's allowing me to assess, and I can draw, the neuroretinal rim a little bit easier when following this patient. And again, I'll say it, is that which image would you like to have plugged into, artificial intelligence? Again, it's coming. So I'd rather have these images here, in there and coming and doing for the future here. So this is just following a patient, with glaucoma. What I try to do here is try to make the optic nerve head images about the same size, because again, you can zoom in. And so I tried making this optic nerve here the same size as this optic nerve so that you can assess and see how you'd want to follow the patient. Now, it's his other eye that is, a little bit more, if you want to say, damaged. And then we're picking up on kind of this little area right here, this kind of macular dropout. What else is going on with with this patient, which is a little bit hard to see over here. And again, being a disease person, I want to be able to pick up these subtleties when following a patient. And again, try to make them equal. That's out there. So you can see to me, it's just that high resolution, that TrueColor. This is almost as over here, like I'm looking with that 78 or 90 diopter lens. And again, looking at the neuroretinal rim of a patient here with glaucoma. Sometimes you get over here, you got a blink, you got a lid blinking here. Sometimes the bright light, trying to get that wide field imaging, but you can see here, same day, same person, nice wide image of the posterior pole. And we're able to assess, what's happening with this neuroretinal rim on this patient. Now, this eye here is the one with, you'll be able to see from here to here, the nerve fiber layer dropout. And even if I look right through here, there's some nerve fiber layer dropout. So it allows me to be able to manage these patients, follow them a little bit closer. And again, you come over to here, now you might be able to imagine it. And again, you can play around with the filters and maybe have that pop up, but I'll just clear these images out. And you can see how cupped we are to the rim here and how cupped we are getting cupped to the rim here on this glaucoma patient. All right. So let's see. This is an epiretinal membrane. This is pretty cool to be able to show the patient. You might be able to do a similar image on an OCT like this over here with the ONFOS, but it's really nice because what you're able to see, you can tell that there's, probably an epiretinal membrane going on here when you look at this image. But what I like seeing is if you look right here, you can kind of, if I draw all this, you can see how this is all kind of puckering. You can see the lines coming in. So we have some contraction right here of that, that scar tissue, that epiretinal membrane that has come from the inner retina and leaking out. You have a PVD, cells leak out, scar tissue grows across, and then epiretinal membranes mature over time. And as you see this maturing, you can see what's happening here, and you can see one right here. All right, so we kind of just showed off the highlights of still images, but now this is where it all comes to be really, really fun with the flicker technology here. It's able to take 2 images and flicker them back and forth. And from what I hear, we're going to be able to do 3 images in the future here. So the flicker allows comparison. We have the ultra wide TrueColor, and we can has also autofluorescence when we talk about the Eidon camera, the wide field TrueColor, autofluorescence, and then the flicker comparison. So I like to call this, do you see it? Do you see what I'm looking at here? So here's a patient with glaucoma, and we have a patient that is from December 11th, 2023, going, I don't know, 6 months, and, looking at this, are you able to, since it's glaucoma, are you able to see any nerve fiber layer, or is there any neuroretinal rim type of changes just in 6 months? And even with, great photography, you can look around, but maybe right here, it looks to be a little worse. I'll get rid of that dot here. But, going back and forth, you can bring some colleagues in and say, yes, no, back, what's going on. Now watch what happens whenever I go to the next slide here. And what's going to happen is you're going to see this. It's going to take these 2 dates. One is up here and the other one is here. And what I'm going to do is at first, I'm going to click right here and just click back and forth. And then I'm going to go over here and click on this one down here, and it's going to play it. Then I can play around with the hertz. It gets up to 10 hertz, which really flickers really, really fast. So you can drag this bar back and forth, and it allows you to kind of see the changes. You can kind of see the wedge defects already right here. But let me clear all this out. And now I'm going to hit play. I believe it's going to play the video. Here we go. So watch that neuroretinal rim in that superior temporal, right where that nerve fiber layer wedge defect was that I showed you. And you'll see that neuroretinal rim expanding. Now, just so you know, I'm not seeing the video playing. It's very small, so I just kind of have these memorized what's happening. And I'm going to go back and I'm going to play it again. It's this area right here. Maybe right in this area, you can see the nerve fiber layer expanding. That's where this flicker technology really comes into play. Watch, I'll play it again here. So great images, but be able to take and flicker these has just been, I've had this camera now for about 2 years, maybe 2.5 years, and every day the flicker technology is just blowing me away here. So I call this, do you see it? Again, it's glaucoma. We always talk about peripapillary atrophy. It does expand. So what I'm going to just kind of point out here, for the sake of time, is the peripapillary atrophy is actually different right here on this April 2nd, 2025. I'm going to clear this, and I want you to look and compare these two. And now that I showed you, you might say, okay, this looks a little bit more peripapillary atrophy. We know that that's part of glaucoma. That if you want to say those alpha zones and beta zones that are out there and expanding. Now watch what happens whenever I play the video here. So again, you can see the two dates are up here. I'm going to go down here. I'm going to kind of flicker back and forth manually. Then I'm going to hit play here. Then I'll play around. But watch in this area down here. I'm going to clear all that off. And now I'm going to hit play. And you'll see that peripapillary atrophy. For years, I said, I never, we go to these glaucoma meetings, we talk about it, and we don't see it. Now I'm seeing it with neuroretinal rim changes. I'm seeing it with neurofiber layer changes. I'm seeing that peripapillary atrophy change. You can see I'm changing the hertz, slowing it down, speeding it up. When you speed it up, sometimes you can see things a little bit easier that's out there. All right. Let's go to diabetic retinopathy. So again, this is another patient, grade this one. Oh, really not see much going on with your diabetic retinopathy here. And then same day, same patient, you can see now that you would probably grade that a little bit different. This is a little bit more scary down here. We talked about that a little bit earlier. We see some dot hemorrhages. We're seeing some exudative changes out here. This retina is a little bit thicker than, it might, we might have thought at first. Maybe some changes out here you could see. So we might grade this one a little bit different than this one. And then I might follow this and manage this one over here a little bit different just based upon, the photo that's here. So this was a patient that came in, and again, I had this great discussion with the patient, and I said, look, this is hyperinsulinemia, your foods that you're eating. Yes, you got to be careful. I'm not going to get into a big functional talk, but I said, look, a lot of this is reversible. The 3 pillars, you got to exercise. You can't be sedentary. That's your sympathetic system, your parasympathetic system, rest and digest. That's kind of our breathing exercises. But the biggest one we talk about there is sleep. Got to get some good quality sleep, shut those phones down at night. We talked about nutrition, got them on some good supplements, talked about, lots of things here. And this is a fun one. And this was very motivating because you could see, this is the picture that I just showed you over here. And the patient actually got better going to here. And you could see the timeline. They really worked hard at improving it. But you could put the two pictures side by side. But where it was really motivating for the patient was whenever we played the video. So now watch, this video here of, again, that's why I go slow. The picture that's on here right now, as you can see, this little white arrows is the one from 2025. And we're comparing it to October 17th of 2023. So you'll see, I'll click it down, this picture will get worse. They actually got better, which makes me feel better in my disease management of this. So again, I'll just click down here to kind of click back and forth so I can find myself what picture is which picture. Then I hit play. Then I start adjusting the hertz, because as you speed up and slow down, you can pick up things that are more subtle by speeding it up and sometimes slowing it down. So let me clear this all off, and I'm going to hit play. So there I'm going down. I'm going to kind of click back and forth, figure out where I am on the dates. I'll slide over and just hit play. Then I'm going to play around with the the frequency. It starts at 3 and you can go up to 10 and go back and forth. You can see there, out flickering it back and forth. You can really see those dot hemorrhages actually disappearing. Typically what we see with our patients is they're getting worse or they're getting bigger. And it's kind of neat because when you do flicker technology, we think that these hemorrhages are static. What you'll see is some areas will get better, some areas will get worse, and you can kind of see what's happening. And I'm just going to play that again for you so that you can see it. So, we talked at the beginning about, the high quality images, and they are, for a first time patient, whenever you're seeing them, you have nothing to compare to. But when you see them back in 6 months and you see them back in a year, or you're taking yearly glaucoma pictures, it really enhances, the care that you're doing. And I got some really cool glaucoma cases coming up here that will really highlight that. Just wait for that to end. Here we go. All right. So again, this is another one. Do you see it? I'm going to go through this one pretty quickly. It's peripapillary atrophy, and it's kind of expansion all the way around, even on this kind of area up in here. So peripapillary atrophy, just expanding with using the flicker technology. This is a glaucoma patient, and that's a biomarker, the neuroretinal rim, neurofiber layer, peripapillary atrophy. Do I have this patient controlled? So watch whenever I flicker it, and you kind of know I flick back and forth, I hit play, then I play around with the frequency. Watch what happens here. So we might say, by taking those photos and putting them side by side, we might say, okay, they look normal. I don't see any changes. But when you factor into the flicker technology, you're able to pick up those subtle changes. Again, I'll say it, plug it into AI, you're going to want to have high quality images that's out there. So, working with the optic nerve fiber layer, doing a lot of disease management. I have patients now. I've been managing glaucoma for 20 years, and it's nice to have, some high quality images. All right, let's get into some 2 fun cases here. Looks like we have, I don't know, about 7 or 8 minutes here to kind of wrap up. This was my favorite, my favorite case. Do you see it? It's a glaucoma patient. So when I do this live, I always tell the audience, I'll buy you a Starbucks, I'll buy you a beer, I'll buy you if you can see it. I tell them it's glaucoma, so it's got to be something optic nerve head. It's got to be something nerve fiber layer. What am I seeing here on this, on this patient? And this is a recent patient I just had, and I know that I always look for it. We always talk about it, and I still missed it. And let me just kind of go and just play the flickers to show you how powerful the flicker is, and why it was, why I literally laughed in front of the patient. The patient says, what are you laughing at? And I just said, well, this is what I love this technology for. So watch inferior temporal. Remember, glaucoma prone zones are superior temporal, inferior temporal. Watch down here. I'm going to zoom in. And watch down there at that inferior. And you'll see that Drant's hemorrhage. And that's an indication that the glaucoma is worsening. It's not controlled. Now, let me go back and do this. Go way back to here. The Drant's hemorrhage is right here. It's sitting right in that area. And I even know to look for it. I even looked carefully around there, had these 2 pictures up side by side, looking at them, comparing them. And then whenever I flickered them, that's whenever I had the LOL moment in front of the patient. It's sitting right there. And I'll clear that. And then we'll go to here, and we're going to play that again and watch. talk about in taking your glaucoma care to the next level. You know, I have cases of macular degeneration. I have epiretinal membranes, diabetic retinopathy. Again, having this camera now for 2.5 years, you know, having the patients come in. Like I said, I was chatting with the iCare's staff, and what we have is going to be able to do 3 images, I believe, is what I was told. So here we are. That was my favorite case, but now this is now my new favorite case that's out. So let me just, for the sake of time, you know, it's a glaucoma patient. So if you look here, I wasn't sure if that was a Drantz hemorrhage. And the reason being is that on the same, I'm going to go over to here, on the same day, there was a hemorrhage right here. Oops, I'm not sure what's playing there now. Let's see where we are. So let's just, I think what you guys are seeing, nope, you're seeing the video again. I'm getting lost in my slides here. Hold on. Let me just push to this. All right, that should be where you are. You guys should be saying, okay, now my favorite case. I had my favorite case until recently, October 1st. And what I wasn't sure was there was a Drantz hemorrhage. And again, I wasn't sure if it was a Drantz hemorrhage because I saw something similar right there. So it couldn't have been bilateral Drantz hemorrhages. Maybe that was just an anatomical finding. So going back to the right eye, just kind of showing this picture, comparing to this picture over here. Well, why I like having it, because I was able to pick up something here, but again, it was bilateral. So I'm like, it's probably just anatomical, maybe some RPE. So the patient came back a year later. So here we are. Now look at this through here. We have nerve fiber layer dropout. We have nerve fiber layer dropout, nerve fiber layer dropout. So let me now play the video of the right eye here. So let's go back before I play. Notice on the right eye, the nerve fiber layer dropout, nerve fiber layer dropout. But what you're going to see when the video plays, watch how it expands. I do not have this person's glaucoma under control. It's going to expand here. It's going to expand here. The Drantz hemorrhage has disappeared. You're going to see this here, this nerve fiber layer is expanding. This nerve fiber layer is expanding. And it's the same thing on the other eye. Now, when you go back and forth between these 2 images, now that you know it's there, it might be hard, it might be easy to see. We can come back to these images, but this is expanding up. And it's getting closer to the macula. That is not good. All right, so let's play the video. Watch what happens here. Watch what happens with flicker. Watch that Drantz hemorrhage disappear. Watch the nerve fiber layer expanding. This patient's glaucoma is not controlled. When was the last time you were able to do that with a camera, right? Be able to, in a year's time, assess, look how the flickering speeding up there. I have that hertz, that frequency turned up high. And you can see that that nerve fiber layer is expanding. You can see the Drantz hemorrhage disappear. And we had to have a little talk with this patient about, you know, getting their glaucoma, getting their pressure a little bit lower. I'm going to play the video of the left eye now. I'm going to start off kind of zoomed out, and then I'll zoom in for you here. Just kind of showing you up the top how I'm flickering back and forth. You know how I do that by hitting that button back and forth. Then I hit the play, mess around with the frequency. But you can see in those areas as I zoom in here, look how that nerve fiber layer is expanding. That Drantz hemorrhage has disappeared. So back whenever I first took the first picture, that was a Drantz hemorrhage. Drantz hemorrhage is a sign that the glaucoma is worsening. And in that course of a year, or whatever the time frame was on this patient, that nerve fiber layer expanded. So it was time for me to knuckle down with this patient and say, okay, let's get your glaucoma under control. So to kind of wrap it up here, as an ocular disease practice, again, this is the opening slide, need photography to see those details, posterior pole, periphery, nerve fiber layer, the ultra high resolution, I'm able to see the fine details of the optic nerve, those trans hemorrhages, the retina, confocality, the image through a small pupil. I have images where I'm able to get through, cataracts. And again, asteroid hyalosis can really destroy a picture. And I really love that TrueColor that's out there, which just kind of mimics, just like looking at the patient with a 78 or 90 diopter lens. So that should put me right about 35 minutes there. And we can do some questions. We can do some answers, and I'll just say thank you. So, and looks like we have questions rolling in here. All right, so let's see here. Do you ever use red-free on photos? The blood vessels really pop. Yeah, you can do some really cool things with both cameras, playing around with, the different filters and red-free and green-free and really highlighting, and helping you assist with treating the patient. What was the pressures of that glaucoma patient? Well, they were all within, kind of, let's say, target-ish. They all started off, say, kind of high pressures, 25, 28, got them down to that 16, 17 range. The one that was the more advanced, the last case, they were probably sitting at 14 or 15. So, we have to get them down even lower because those were some pretty cut nerves. And even at, 14, let's say on an average, that wasn't low enough. And that pictures, kind of shows that we better do something or they're going to be in jeopardy here. And they were younger-ish patients. We always treat them now to be 100. Now I do 105. And so we had a long way to go with those nerves and that amount of damage. All right, so let's say, would some of the optic nerve cupping changes show up on an OCT? Well, the optic nerve head cupping, if you really knew how to look at some of those parameters of the optic nerve, which none of us, I look at them, you might be able to pick up some of the changes on there. But, we usually look at nerve fiber layer and GCC. So, that's why we can't make this, chronic diseases. We can't make them linear and binary. We need all the tools in our tool belt to be able to manage these patients. We've relied on OCT for so many years. We almost feel that it's the gold standard. It's really not. It's not even the standard of care. Not everyone can have an OCT. So the standard of care is still, optic nerve head imaging that's out there. So you're treating glaucoma, is OCT a standard of care? They would argue no, because not everyone has it, but everyone has a camera, so photography. So if you're using the standard of care that's out there, that's why, again, a high resolution camera is really, really valuable. Question is, do I use fundus autofluorescence and OCT for my plaquenil patients now? Yeah, the answer is yes. Trying to pick, if you think about, plaquenil toxicity, it's an outer retina, it builds up into the RPE. So it creates a toxicity. And the bad thing about plaquenil, the half-life of it is like 40 days. If you look that up, it's like 38 days, 40 days. Some medicine is like 1 day, it's like 12 hours. So when it builds up into the RPE, it can really be toxic to the RPE and to that outer, outer retina. So when you're managing patients with plaquenil, or looking for plaquenil toxicity, you really want to, use all the tools in your tool belt. So obviously, high definition spectral domain OCT, not time domain, but spectral is what will pick that up. And then coupling it with a camera that can do fundus autofluorescent will really help you out. So we have a classmate here. It's your old classmate, Rain. How are you? So I wouldn't say old. We're still young, Rain, that's out there. But you've had the camera for 6 months and love it. Thanks for the Thanks for that shout out, 1995 PCO, right? So PCO, now Drexel. Thanks for being here, Rain. All right.
Dr. Caldwell, there was one earlier one that said, how do you take asteroid photos since it filters it out?
Well, that's going to be how do you take asteroid photos since it filters it out? That's my technician. She just goes in and takes the picture, and I don't know if I don't know how the camera works around it. If it's the confocality of it, I don't think it's the high resolution. But if there's someone from the iCare team that can help us out with that, how it works around cataracts and asteroid, all I know is I'm pleased that it does. So. Oh, how do I take photos of asteroid? How do I take asteroid photos since it filters it out? I'm not, I could take it with my anterior segment camera if I need to do that. I'm not sure if there's a way to turn off something in the camera of the Eidon. I really don't need to have a picture of it unless I want to show the patient. So if the patient wants to see it, I can just use my anterior segment camera to do that, if that's the question. How do I take asteroid photos since it filters it out? What other questions, or does anyone from the iCare team want to make some comments?
I don't see any other questions coming in. And my name is Dave Greiner. I'm the area sales manager here in the Northeast. We want to thank everyone for coming out this evening. Dr. Caldwell, this presentation has been great. I like to see different things that doctors do and find, and your enthusiasm through it, and utilizing multiple devices is outstanding. Each of you that's on the call tonight has an area representative that would be happy to answer any additional questions that you may have. And I challenge you, if you're interested in learning more about the Eidon, most of our reps will provide you a free demonstration. I love to challenge my territory people to do a half-day demo. Take a picture, as Dr. Caldwell did, same eye, same day on the current camera that you have, and compare it to what the Eidon provides. After 4 or 5 patients, you already know that there's a big difference. So we'd be happy to help anybody in any way. Please reach out. And if you want to schedule something, reach out to the iCare team. Dr. Caldwell, thank you so much for your time this evening. If anybody has any other questions, I don't see anything in there. Somebody just commented that they have the Compass, which is our visual field and retinal camera all in one. It's a 2-in-1 camera. Again, more information is on the website for that one also.
No, this was actually an honor and a pleasure. Again, kind of out of a surprise. It was in my latest innovations, and I was just super excited to be able to show those Drans hemorrhages, that diabetic retinopathy, all the different nerve fiber layer changes. And I'm happy that someone from the iCare team felt that it was useful, and ending up here tonight. My passion is to teach. I love teaching, and to be here tonight and to be able to do this is truly an honor and a pleasure. And I just want to repeat to everyone out there that's still on here listening, I'm not being compensated here tonight. It was I don't want to be compensated. If you go look at my disclosures when I do COPE, you're not going to see the iCare name on there. That's out there. So they asked me to do this, and I said absolutely, because this is one of the fun parts of my latest innovation. So I want to say thanks everyone for being here. I want to say thanks to Jobson for coordinating this. It was a great team with this new technology and this platform. It worked really, really well, and so it was a great team effort. I want to thank everyone for allowing me to, and for you being here tonight and spending your evening with me.